fat. So it is a adipose tissue commonly known as body fat, is found all over the body. It can be found under the skin, which is the subcutaneous fat area, packed around the internal organ, which is visceral fat, between the muscles, within the bone marrow and the breast tissue. There are different types of adipose tissues: white adipocytes, beige adipocytes, and brown adipocytes. So what is the basics of the body fat? White fat, it is an energy metabolism, it insulates the heat, it provides mechanical cushioning, it's a very large cell with very little cytoplasm, small nucleus, and more than 85% of the volume is composed of the fat droplet. Brown fat, on the brown fat side, it is found mainly in the children. Its thermogenesis related to skeletal muscle composed of many small cells with many small fat droplets of the adipocyte. Adipocyte tissue has historically been classified into two types: white adipocyte tissue and the brown fat, which are visibly distinguishable based on tissue color during heat production, which is critical for body temperature maintenance. So, you can see how is the body fat percentage. There is variable resorption of it. With fat grafting, anywhere from 10%, there is total survivability. Otherwise, there is a necrosis of the tissue. Now, there are zones of fat survivability. There are three zones: surviving zone, regenerating zone, and necrotic zone. So, where can we use a fat? It can be used as a volume enhancer. It can't be used as a augmentation because it will fail. So, there are some pros and cons of it. For the pros, autologous fat from your own body, we can harvest it from the abdomen or anywhere in the body, thighs, as opposed to dermophilus replaces with like because it's own body. Fat transfer results in natural, long-lasting and safe. Fat transfer is non-invasive method for achieving facial rejuvenation. It improves the vascularity of the area and rejuvenates the skin to prepare fat tissue before transferring it, compared to the dermophilus, which are provided directly. Though longer lasting than dermophilus, fat transfer costs more because of the surgical procedure. For augmentation, you may require multiple sessions to achieve desired look. Once injected, it is almost impossible to remove completely if overfilled. It can assure vascular compromise if injected directly into the vein. So what is the versatility of the fat transfer in survival? The Coleman technique is the standard and preferred method for harvesting and the processing of the fat. There are three steps of the fat transfer: harvesting of the fat, separation of the live cells,
So patient is very happy in getting this and came back to life. This patient was a temple pujari, so he could speak, he could come back to his regular job of chanting mantras within a month and went to the job. So this is one more case where the implant, PSA implant, we have taken it to the floor of the orbit and extended to the zygomatic arch and the lateral wall of the orbit. By taking the support of the zygomatic arch and the lateral wall of the orbit and the adjusted maxilla, so we could rebuild the zygoma. This is the facial form which we could get. So this is one more case of complete maxillectomy which was done. So in this, we can see how the patient's dull-looking face has become lively within a month. So that's the advantage what we got with the PSI implants. So this is one more case. But as we have started doing, he doesn't want any other defects. So we have to go for a prosthetic operated later after giving a teeth. So this is one case where we have placed a PSI implant and take a radial forearm flap and try to close. A preoperative X-ray of one patient. Here we used a proper guide. A normal other freehand zygoma is very difficult for in these cases because we don't have a proper zygoma implant guides and place an implant. This is a result which we got in this patient. The disadvantage in
often hailed as the fountain of youth or elixir of youth, basically works because whenever it's activated, it releases to this growth factor, fountain of growth factors, the biotransformation. This was monotherapy as well, no microneedling. Third session, patients start showing results. This was plain PRP with no other just process for diffusion. For the dark circles, this was the third sitting as well. A 40-year-old lady came to me. She was already treated with 3 sessions of triamcinolone, and after 6 months, she did not see any changes. So she sought treatment with PRP, and this was the result after 3 sittings. That is the third one. When we search for PRP in general, the PubMed shows over 5,000 publications, and just the plain PRP, there was loss of platelets, and there was a lot of variables involved regarding the processing. We did not know what is detrimental to healing and impair the inflammation, and chances of contamination was more because the packaging was not sterile. When we search more literature, because we wanted to establish a SOP when we were doing PRP, so that we could found that regarding composition, standardization, there was no protocol. The utilization of the activators as well as the composition of white blood cell, which we could not regulate with the plain PRP. Articles suggested how to go about the limitations of literature. We found some product called the growth. In this thing, there was a sterile packaging which was available. It was marked BCs or RBCs. The WBCs would bring about inflammation and then post-procedural pain, which was absent in the growth factor. And this product could be stored for 7 days at 4 degrees centigrade. And it was better than just using the plain PRP. The collection of blood in Vacutainer in whatever is available. This is just one system, but there are a lot of growth factor concentrates which are available in the market. This one had more literature, so the evidence pertaining to this was more, so we used this for the patient. The mixing or activation of platelets was done by gently inverting it 6 to 10 times and allowing it to stand for half an hour. That was already mentioned. There was no such standardization with plain PRP. The time was mentioned as well, that is 10 minutes. Earlier it was like single spin 10 minutes, then go back to the double spin. Some people contradicting, saying the double spin will result in loss of platelets or loss of the morphology of platelets. So that is the growth factor concentrate we get at the top. The number of units which we can inject is mentioned as well. That is maximum of 6 units what we can inject in the scalp. Maximum of 6 to 8 units which we can inject in the skin.
What is common between both of the surgeries? So what I do is I usually give Botox either a week before or else on the same sitting. So what's that going to do for me? That is not going, that's basically going to relax the muscles. So if the muscles are relaxed, there won't be much of the contraction or the movement or that particular region, resulting into less scarring in that area where we have taken the stitches. The other thing that I told you is this orbital gland prolapse. So suppose if an old patient comes to you with such a thing, or else you can just manually check it while you retract this particular region. If at all such thing is there, you need to resuspend it to the this orbital cavity inside. These are my references. Thank you so much. Any questions?
Excuse me. The topic of my presentation is facial scar management with hair transplant. Cicatricial alopecia is a difficult problem to deal with. This is a 26-year-old male patient who presented with a scar on the right cheek area following a burn injury sustained 15 years ago. Subsequently, the patient had undergone serial excision of the scar tissue in a different hospital. He complained of widening of the scar and resultant facial asymmetry due to depression in the malar region as well. The scar extended from the right sideburn area onto the beard area involving the chin region The difference between a scalp tissue and the facial region is the direction of hair keeps changing. Hence, the coronal slits needs to change according to the area that we are grafting it in. So, the periphery would have a more feathery look. So, the coronal slits would be in a different direction, whereas in the cheek area, it would be more coronal, indirect, more parallel to the midline. With 18 gauge needle, after which almost 2 to 3 follicular units were harvested into it, with which gave the density was 35 to 40 grafts per centimeter square. The patient was then kept on routine antibiotics and analgesics and was asked to moisten the area as post-op instructions with normal saline. No minoxidil or fenestride was advised to the patient, since fenestride is an anti-androgen which is not recommended in the beard area or the armpit area or pubic area. Go for a hair transplant sitting on the opposite side so as to match the level. So in conclusion, I'd like to say cater to the patient's needs. It is a challenging thing because beard area it needs to be subdivided into facial subunits and it is multi-directional in nature. The one major factor that needs to be considered is the scar tissue should be soft and supple with good vascularity, no hypertrophy. In medication, topical application of tretinoin and acetretinoin synergistically with minoxidil. Minoxidil application is a controversial topic in this. Some say that if there is a burn tissue and there is no follicular unit left there, as in to harvest into it, then minoxidil would not help. So it is a matter of like controversy. But no finasteride, which is a complete no because it's an anti-androgen. Other methods that could be used instead of hair transplant are micropigmentation, microneedling, increased hair growth factor application, low-level laser therapy. I'd like to acknowledge Dr. Nishant Karim, Dr. Amit Kothari. Thank you.
Our chairpersons to kindly come on the stage for distribution of the certificates. Dr. Bala Jagannath Gupta. Dr. Rajshri Bandyopadhyay. Dr. Inos Stewart. Dr. Aditi Agadia. Thank you very much, sir and ma'am. Now it is my pleasure on behalf of scientific committee to present certificates for chairing the session to sir and ma'am.
Good morning to everyone. Thank you, chairpersons. And thanks to the scientific committee. I am presenting in the last session because there was some technical snag very in abstract. That's the reason. I come from the Premier Institute of Indian Army, the Army Data Center Research and Referral from Delhi. Basically, this is a basic topic. TMJ is one part. Even after many years of experience, people don't have so much of confidence to approach the TMJ. Basic condylar fractures, whatever it may be. So the basic aim of approaching the TMJ and how we approach the TMJ ankylosing. That is why this topic has been taken. What basically is an ankylosing? Ankylosing is stiffening of the joint. As we all know, the word ankylosing means stiffening of the joint and abnormal immobility and consolidation of the joint. That may be due to any other reasons. Either it may be congenital or it may be occurred due to post-traumatic ankylosing. What happens during the condyle development of the condyle? At 7 years, the articular tubercle becomes very prominent till the age of 12 years. Then the temporal element is critical in the lateral growth. what happens? The disc changes its shape over a period of time. It becomes compact, less cellular, and collagenous. The mature disc at the end is avascular and aneural in the central portion. Out of the three portions, the anterior, middle, and the central one is avascular. And whether the patient gets enough nutrition at whatever age he may be to maintain his oral hygiene, to treat obstructive sleep apnea, and to enhance his normal growth. Apart from that, where every individual has the right to be normal, to get good cosmetic correction. This was a case which came to head as the unilateral ankylosis. The clinical features basically are, you have an asymmetry, the deviation of the mandible and the chin to the affected side, roundness and fullness of the face on the affected side, and flatness on the unaffected side. Basically, the mouth, he had a restricted mouth opening. You can see a class 2 malocclusion and a posterior crossbite on the ipsilateral side. The condylar movements are absent on the affected side. The basic thing is on the orthopentamogram, you can see a left side there is a prominent anticonial notch. In the case of bilateral ankylosis, it will be a class 2 malocclusion with an
very important. Methylene blue has to be applied to show you where the slits are, and then you start making, you put the methylene blue, these are the slits just to make a little bit of grafts on this side corner of the mouth as well. And this is methylene blue. Once we have done that, we can easily see the slits and we start putting the slits. It's a little tough when you're going to be doing it in the scarred area, but once you start developing your practice, it will become, see, it's a little tough when you kind of push it into the scarred area, but I think it will be great when you do a lot of cases. Yeah, that's how we do for the mustache. So you could do it for the scars, cleft lip scars, that's what I mentioned. I'll just skip. Okay, so eyebrow is another indication which you can do. So a lot of people do eyebrow micropigmentation or microblading, but many a patient asks, no, we don't want microblading, we want something more natural. So you could harvest hair from the, whichever the thinnest part. So most of the times the thinnest part is from this area. So what you can do is you can take the hair from the temple area here, and then that is what you can actually harvest from there, and you can put it here. So the only problem is the anagen cycle of the eyebrow hair is much lesser than the anagen cycle for this hair. So you have to explain your patient that you got to keep on trimming those areas, because eyebrows normally, when it goes from anagen to catagen to telogen, they fall off faster. But here it's going to be a different story altogether. So you have to explain your patient that they have to take a scissor and keep on cutting it every 15, 20, 30 days. That is one thing we must explain to your patient. And once you do that, you start pushing it. Again, angulation is very important here. Do not put your angle at the slits like this or like this. So you have to be along with the eyebrow, so you will have to make the slits there, and you start putting it there. Bang on time. Thank you so much. People are sleeping now, ma'am, so we have to wake them up.
Yeah, it was so interesting and everybody was watching with rapt attention. Question answers we'll do in the end, I
Sure,
think,
ma'am,
together.
no problems.
Speaker, Dr. Gopal Krishna for non-surgical facelift.
Yeah, good morning. It is the largest organ in the body. It's made up of 3 layers: epidermis, dermis, and subdermis. So we mostly target this epidermis and dermis most of the times. And what is aging? It is a process that accumulates changes over a period of time. It can be either intrinsic or extrinsic. Intrinsic is the normal chronological aging that occurs in every individual, and it is inevitable. However, it starts by 20s. By the time the results are seen, the patient is almost 40 plus. And extrinsic aging, these are the external factors which accelerate the intrinsic aging and the normal aging. So what are these external factors? The main cause is sun, the ultraviolet light. It damages elastin, collagen, and it causes all the wrinkles, mottling, etc. And other than that, you have cigarette smoking, gravity, sleeping position, excessive facial expression, and being overweight. Now, this was something, as Atri had already said, you will have some fat redistribution accumulation and atrophy. Some areas lose fat, like forehead and cheeks, and some gain fat. Okay? So now what are some of the signs? Because most of the time when we do something called as non-surgical facelift, these wrinkles are the ones we are mostly addressing, or sagging skin. So some common wrinkles are forehead lines, frown lines, crow's feet, tear troughs, bunny lines, Marriott lines, nasolabial folds, mental crease, and neck lines. And some people have the ability to age gracefully, but however, not for everyone. So what will this facelift do? Facelift will tighten the jowls and the cheeks and the skin of the neck and the neck tissue and softens the smile lines. A surgical facelift is always an armamentarium of a surgeon, but it requires multiple incision and sorry, and it's also associated with quite a number of complications. Whereas non-surgical facelift is the use of minimally invasive non-surgical procedures to address the rejuvenation and to lift. It helps in both rejuvenation and lifting. But however, it's most of the time not a single treatment or a single procedure, and it's a combination of multiple procedures. So right now we are addressing it as Botox. It was approved by FDA in 2002, and wrinkles. But only thing is, wrinkles cannot be totally eliminated by Botox required, and effects can last 3 to 6 months. But
Dr. Amarjeet Gopal Krishnan. Dr. Paul Mathai. A certificate of appreciation to our chairpersons. Dr. Jitendra Arora. Dr. Govind Ramesh Rao sir.
infraorbital area, nasolabial fold, mouth frown, pre-jowl area, and the jawlines. Now, what are these 8 strategic points of injection?
Contracture because of the filler, it will block itself out. It will not let the filler pass through. That is where the site of damage becomes constricted, especially in the glabellar region. We have a lot of choke anastomosis. That is, in normal situation, it will allow your blood to pass through. But in abnormal situation, it will cut off, it will stop, it acts like a gatekeeper, preventing any more filler from passing through. That way, the tissue can be salvaged. So now, unaddressed. So in the first stage, what happens is you will have blanching. Blanching is initially, if you don't take, the capillary refill will be lesser, will be more than 2 seconds. If that is not taken care of, in the next 72 hours, it goes into livedo reticularis. That is, you'll have a purplish hue to that area. Why is it happening? Because there is venous congestion, which is seen. I've already said before, if there is venous congestion, your microflora changes, your microflora becomes bad, so slowly, the skin goes into coagulation and necrosis. You leave it just like this, it's going to go into eschar formation and loss of tissue. Okay, so now treatment is important. As I already said before, reversal is the key to it. The earlier you recognize, the faster you have to reverse it with hyaluronidase. Along with it, you have to give thrombolytics like aspirin, which has to be started simultaneously. But time of onset is very, very important. The more, always remember, skin has an ischemia time of 24 hours. You do not take care of it before, the more damaging the issue is going to be. Okay, so hyaluronidase, this is very important. You get it in vials of 1,500. You have to dilute it in 1 ml, and you get in every 0.1 ml of it, you will be having 150 units. Now, every site, this is the high dose hyaluronidase treatment which has been implemented right now. So, according every area, you have to introduce 500 units. In the first one, it's one area. Second one, you have the nasolabial and the nose. So 1000 units. Again 500 units. Now you have the chin, your nasolabial and your nose and glabella. So again 1500. But always remember, hyaluronidase has a very short shelf life in your blood. It gets dissipated and dissolved very fast. So every hour you have to see the site which is happening. The first case probably you require 1500 units. Probably in the next time when you again re-evaluate, you might see that from 3 sites it has become 2 sites. So again it has to be repeated every hourly till you see that the site of injury has completely dissipated. Again call back the patient after 24 hours, redosing might have to be done. Patient has to be evaluated every day to see the site of injury. You have to immediately start dressing, put the patient on antibiotics. On the first day, aspirin is important. You start them with 325 mg on the first day. Next 7 days, 81 mg has to be continued. Simultaneously, you have to start the patient on antibiotics. When you're doing it, you can implement massage and warm compress. Pustules, as which you have seen, you're supposed to do regular dressings of it for 7 days so that the rate of scarring is very less. Okay? So now visual. Visual complication. Now this is the most tragic complication which can occur in our field. This is what I was talking about when I talked about the first slide about the questions which I've asked you. Now visual complications usually are rare to occur, but if they do, are usually seen when you inject your nasal and glabellar region. Most common in Asians because they have a high prevalence of getting their nasal augmentation done. Okay, so now when you're understanding this, these 3 main ICA branches, or you have branches of EC, superficial temporal artery, which all anastomose with your ICA. So either you have introduced into ICA or you have introduced into ECA, which has entered into your ICA. So this is where the anastomosis occurs from the ECA to ICA, even superficial temporal. Comes an anastomosis with your supratrochlear and supraorbital. But always remember, when you're talking about it, the diameter of your cannula or needle is very, very important. Smaller the needle, smaller the cannula, it sits inside the lumen of the vessel. Now supratrochlear, supraorbital, the vessel diameter is 1 mm. Your needles which are smaller are 0.3 ml. The chances of it sitting inside the lumen is very high. Smaller the lumen, more the pressure, because these are viscous material. So the chances of it undergoing embolism is very high. As you can see, the larger the diameter, lesser the chances. You might penetrate through the vessel, but the chances of it sitting inside the lumen to cause sudden embolic event is very less. And distance of the entry from the orbit. The closer you are to the orbit, the higher the visual complications. That is your supratrochlear, supraorbital, dorsal. Now coming from your superficial temporal, your supralabial or your superior labial or angular, the chances of it occurring is more, it becomes remote the farther you go away from the orbit. So that is why I talked about nose and glabella. The closer it is, the visual complication rate is very high. Now so these are the symptoms which occur. Ischemic tolerance time is very important for your retina, for your cornea and retina. Ischemic time, the more the metabolism of the tissue, less it can tolerate no oxygen supply. In your retina, the ischemic time is just 90 minutes. So you have a 90-minute window to work, otherwise the tissue damage which occurs is irreversible. When you're talking about brain, it's 1 to 3 hours. 1 to 3 hours, so we have a longer period window. When it comes to skin, the ischemia time is 24 hours. So you can understand why that emergency occurs and you have to act in those 90 minutes, right? So check for, the most important thing is we have to dislodge the embolus which has lodged itself in the central retinal artery. But as I said before, it is an end artery. For us to introduce hyaluronidase, do this 3 to 4 times because of the pressure and release, sometimes the emboli might get dislodged. Along with that, you can start them on acetazolamide, mannitol, heparin, aspirin, because all of these are vasodilators. Right, now coming to the last, I'll try finishing this up. So what you can do to avoid it, what I tell all new injectors is, as much when you go for cadaver dissections, try doing this technique on a cadaver because emergencies like these don't happen often, right? And when it does, you should be at least attuned because the pressure is a pressure situation. The patient is extremely anxious, and this is not something you should do directly on a patient when it's happening to you. So as much as possible, try doing it in your cadaver labs. So retrobulbar injection, your retrobulbar area, which is posterior compartment, has your short and long ciliary vessels, which somehow have connection with your central retinal artery. So your retrobulbar area is 25 mm behind in the orbit from your anterior orbital wall. So you have to take a long needle, 25 gauge, 38 mm needle, 38 mm cannula, from 2/3 from your medial, 1/3 from your lateral. There's a point which you enter. Take the cannula inside, scratch the orbit, go to the retrobulbar, go to the depth of the needle, introduce 1500 units of hyaluronidase. Wait for an hour. If the things don't improve back, do it again. Probably 2 to 3 times introduction of 1500 units is required in the retrobulbar area. But the chances of your embolic, if it is lodged, remember, prevention is the key. The chances of hyaluronidase acting in the central retinal artery is very, very remote once it occurs. So as much as possible, you can do the changes, but the visual, changes recovering back is very less. So prevention is all. So this one last slide.
I want to understand from the audience that how many of you are into facial aesthetics practice right now? Like how many of you are practicing? Please raise your hand. Okay, not many. How many are interested in facial cosmetology? Okay, I see a lot of hands. How many are interested in other branches of maxillofacial like trauma, onco, cleft? How many are here? Okay, cool. Interested in maxillofacial and are willing to broaden their horizon of practice. Plus, I want to make you all understand the importance of facial aesthetic procedures as such, combining with other maxillofacial procedures that we have. We have a wide gamut of procedures that every one of us are interested in, including trauma, onco, cleft, TMJ, craniofacial, lot of things. But I would want to tell you that the final touch that you can give to boost the confidence of your patient would definitely be the cosmetic procedures, the aesthetic procedures that is there. And I'm going to talk about the same thing today. So to briefly introduce myself, I'm a maxillofacial surgeon. I have done specialization in facial aesthetic, facial cosmetic surgery, and I'm based in Mumbai, India. Now, before we even get into our topic, can you all, now this is a little interactive, not very much because we have limited time, but do you have any idea that the aesthetic procedures are want procedures or are need-based procedures or whatever it is? Can anyone tell me what is the prime thing in aesthetics? Is it want or need? Want? Want, right? Okay, everyone agrees that it's want. Is it need also at times? Yeah. So we are going to talk about these things because understanding that facial aesthetic procedures are want-based procedures. Patients want to do it because they want to look good. They want to boost their confidence. And that is the prime bread and butter practice, I would say, of cosmetology. Now the gamut includes the want-based procedures in general, includes anti-aging procedures, which would make the face tighter, which would take you back to where you were a couple of years back. And then there are skin procedures which would make the surface of the face look beautiful, the skin, including lasers, chemical peels, etc. These are the procedures which are broadly there when we talk about the want-based procedures or facial aesthetic procedures. Now, certain examples, if I may give you, would include when a patient says that I want to look young, I want a rejuvenated face, I'm looking tired, okay, I'm not looking fresh, or at times we get budding model actors, etc. They would say that my cameraman says that the shadow is not falling, so I need to correct it. My eyes are looking tired. So they would come with such complaints, and these are the broad aspects where the patient comes for want-based procedures, including anti-aging for that matter. Someone who is aging, they want to age more gracefully. So they would also want to do these procedures, including anti-aging, facelifting, where a combination of, you can give a combination of Botox, fillers, threads, then you can give a little bit of fat lipolysis injection if they have double chin. You can use HIFU also for lifting the face. For example, in this particular face, a lot of procedures have been combined together, including face lifting with the help of threads, including under-eye fillers, including little bit contouring of the face to bring the face back to the golden proportion. Then there are surface procedures that has also been done to make the skin look good and overall causing the anti-aging of the patient, because patient wants to look good. Then there are certain skin lip depigmentation procedures also that are want-based, color and such things, which are also permanent lip colors, permanent eyebrows, etc., which are also very common. Then we also have in want is the under eye dark circle, under eye hollowness. These are the certain examples of the procedures where patient want it, So that is it. At times we also get patients where they want to look a little slim. They feel that their face looks a little bulky and they want to make it look a little slim, which covers the broad gamut of facial aesthetic procedures. And as a facial aesthetic surgeon, I feel that I get a lot of patients like this who are willing to get it done because they want it, and of course they are ready to pay a lot of money for it, because girls would know better. When you go to a salon or a parlor, you would pay anything. Do you bargain with them? No, because you feel there is a risk that if you go maybe to a cheaper salon or maybe to a place where all the services are not available, you would be scared that you don't want anything to go wrong with your haircut or something like that. Similar to that, when these people come for a facial cosmetic procedure, first thing they don't bargain because it's a want based. Also one thing which is there to this gamut of procedures is the need. Or in general maxillofacial surgery, they need to understand.
Excuse me.
Dr. Neha Abhichandani. Dr. Safna Vadira. Prasad, to please come on stage and present the certificates to the chairpersons. Dr. Madhumati Nidros.
And what happens is that the amount of shedding becomes less and the amount of accumulation becomes more. So the skin tends to look rough, the texture becomes very uneven and it becomes thicker. So it's very important that you use skincare products or procedures that helps you to resurface your skin or which allows your skin to shed on a regular basis so that the skin is good and you have a baby healthy skin. So I would ask
you would like to understand here is, one is the aging process, what damage it has done to the skin. Second is the photo damage, what it has done to the skin. So in terms of these two directions, you would want to give the patient a bit of information how to go about it. So Dr. Mimasa, can you tell about both the aspects? One is the photo damage and the aging skin.
So for this patient, something that was reiterated by Seema ma'am and taught to me by my mentor in aesthetics, Dr. Anisha, so was that 30% is what we're going to do as treatments and 70% is what they're going to go back home and put on their face. So you do 100 treatments and she doesn't wear a sunscreen and steps out tomorrow, it's just going to worsen. So a very important aspect reiterated here is that. So we did very basic things for her as she did not have any major issues on her face. As you can see, no resurfacing is needed, pretty much a plain face, no acne, no eruptions, no breakouts. So for the glow, the easiest thing to do is, I feel, going for a simple basic peel, which helps in shedding, easing the shedding of the skin, and then going for some micro needling sessions with glutathione based cocktails, which help in lightening and brightening, which was her major concern, that she felt she has a dark skin. So we can go to the next slide and we can see the pre and post, and then we can decide if we could have gone a little differently. So.
So at this point in time, I would like to take methodologies how you can resurface the skin. First one is the what has been told, the topical medications, then is the chemical usage of chemicals, physical, and then light source. So energy based sources. So any other modality you would want to think in those terms? Or?
So first of all, because as it has been mentioned that skin turnover rate, between exfoliation and the new skin coming up, there is a fair amount of gap there. And that is the time your connective tissue is responsible for. So we have to plan forward. So when I would do this case, peel would be a very good option because the patient comes to you with expectations and they want results which show, right? So if I want to combine something with this, since I don't see any pigmentations, I would not go too much into energy-based devices in this case, because every kind of energy-based device that you use will at some point of time slow the skin turnover rate, because it inevitably damages the underlying tissue, okay? Unless it is resurfacing, even there. So I would like to combine this with some amount of growth factors to start with, because it increases the skin turnover rate, it nourishes the tissue, and gives sustainable results. So keep it very simple, not making it complex or not modifying it too much. Just do the same thing, but this needs to be repeated. And yes, any amount of UV damage is so bad for the tissue that it will stay. So whatever you do comes back to point zero. So the patient compliance is of utmost importance. So very rightly said, if the patient compliance is poor, your results will not be sustainable, and the patient's expectations will not be up to the mark. So yes, look forward. Once you've done the treatment, look at the next step. That is what I would say. Growth factors is what I would combine it with.
I would also see sometimes what happens, the skin also has hydration. So you can incorporate non-cross-linked hyaluronic acid or fillers to hydrate the skin. So that allows the absorption of water, it hydrates the skin, and you get a natural glow from inside out.
At this point in time, two important.
So for her case, to be honest, not for every case, any other priming treatments for her, what I underwent with her is, because I see a lot of tan, in this image it's actually more clear than that. It looks very fair on that, so I don't know. So basically, you have to tell the patient to be prepared on the first day itself, mentally prepare the patient about everything that she is going to feel. All the post-op things, from immediate post-op to later, to not doing certain things, to not stepping out in the sun. So mental priming is something that is, I think, we miss out in our cosmetic treatment planning. Psychological priming of telling the patient that this is what you're going to experience. Don't expect, suppose we are doing a microneedling with a PRP, don't expect that the next day you will be looking white and fair and nice, your skin will be tight. Because when they get up and they open their eyes, they're expecting that after 45 minutes of a session, they should be looking really nice. But they'll be looking worse. So that is one thing. And yes, I what was the question?
In the audience, we have anything on the price?
PIH is something, when it happens, the only thing which you can do.
No. One more is
Post-inflammatory hyperpigmentation is something. PIH or post-inflammatory hyperpigmentation is something which can happen when you are not very careful about using energy-based devices or even chemical peels when you're doing resurfacing. Do you guys know what is the only thing that would help you in PIH or help us in PIH? Pray God. That's the only thing which is going to help you. Because once PIH comes, it's not going to go away in 7 days, 10 days, 15 days, 30 days, 40 days. It's going to take you for a while. So the only thing which you should do is just pray God. And of course, the sun protection is very important. Do not do anything for the first 1 month, 6 weeks, 7 weeks. Don't do anything. Just tell your patient, sit quiet, stay at home, or whatever is, use nice sun protection. That is when you are allowing your new skin to come up. And then you can start doing whatever you want to do. Do not rush. That's the only thing. You have to listen to the patient's nice songs, but that's okay. But you have to do it. That's what I personally feel. Once it is done, wait for 6 weeks, only sun protection, and then you can start slowly doing other things. Like you can start giving them mild amount of hydroquinone and things like that. That's
so how I do it is, if a patient is undergoing a peel for the first time, I always put them on a skin lightening cream for 2 weeks and then do the peel. So I give them a night cream for skin lightening. If it's an acne patient, it can be an Azelaic or some retinol-based product. I asked them to stop it 4 days prior to doing a peel and then do the procedure. So what happens is you're sort of preparing the skin to sort of accept your treatment and your product, and that is very, very important. That also creates a system of your procedures only lasts for a while. And then they'll come and say, doctor, you did this and our skin is back to normal, you know. So it's very important that you inculcate that habit and you know the seriousness of a patient when you do that, whether they are motivated to do your treatment or not. So that's very, very important.
Why I would like to say is that is going to happen. It will happen whether you use peels or lasers or whatever else you want to brighten up your skin. Though it's a superficial procedure, all of these procedures are going to dehydrate your skin. You know, it's not that you start looking great. You have to take more care of the skin after whatever you may have applied on it, peel or otherwise. You have to hydrate it more. Like she says, she would use hyaluronic acid. That's an additional expense to the patient, of course, when you're going to charge for that patient. But the fact is that any of these processes are going to dehydrate your skin. They are not going. It's not going to feel nice. It'll feel drier. So you're going to tell them to use more of their moisturizers and everything also. And our skin has lost. What are we doing? We are cleaning up the dead skin cells, which are actually needed naturally by our body because they are supposed to protect us from the sun rays and UV rays. You know, we need those dead cells and they gradually fall off. That is what we were learning on this one. But now what are we doing? We are actively stripping it off. So when we strip off that layer, what happens is the UV lights are going to directly impact our melanocytes and they are going to become very active. So peel ke baad or whatever process you are going to use, the skin is going to darken in 2 seconds if you just step out into the sun. That is why we are telling the patient, understand this, that once you walk out of the clinic, you are going to be in trouble if you don't take care. So all the shine will look good there, and when you step out, they come back and say, "Hum to double dark ho gaye. Now what have you done?" We have had patients who have not paid attention to this thing and they've come back with...
Please take AOMSI ka indemnity scheme. Please do that because it's my personal experience. So it's my personal experience. 1 in every 30 patients are going to come and tell you, I am going to report this. I am going to sue you. 1 in every 30 patients. So better you take AOMSI is our body, so we can take AOMSI. But you can take anything.
Or take the cheapest cosmetic indemnity. It is the cheapest.
I want to add a point on priming. Priming has to be done at times, but it also depends a lot on, you have to discuss with patient what is the time frame they have. Because what happens at times, they are really bothered about this when they have to actually attend a function, a wedding, or get married. Then they would be like, ab kuch karwana chahiye, and then they would come to you. Really at times don't get time for priming. So based on all these things, you have to make a call, and also deciding a peel or a laser also needs to, you need to take in count what their time frame is, because certain peels have a lot of downtime. So you need to understand, because patient would be like, peel karwa ke kal shadi. That happened with me once. Yeah, a patient came for me for laser fractional CO2. He didn't tell me that he has a wedding in a week's time. So I asked him not to go out, take care, everything. And then it's like, shopping to karni thi, shadi ki preparation, and also you have to make sure that you are keeping in mind all these things before deciding the type of treatment that you're choosing. And priming as well.
Psychological priming of telling everything.
So, listening to all this, we all have such practices where we have such patients coming in. Now, you have, suppose I give you an example, which is a routine thing that will happen to all of us, by the way. You have a patient who's a public figure, who can't avoid sun exposure, let's say an athlete, and they want the same. Would you want to take this patient up? If not, why? Because they don't, they're public figures, they have to face the screen every time. What do you do? So we have this situation coming. There, the first thing that you will actually have to do is, you can't say no, right? You will have to tell the realistic figures of expectations to the patient and what they are expecting, okay? They've got so many commitments up front. You say, example, a cricketer or a footballer or anyone, any sportsman, an athlete. Can they avoid sun exposure? First thing, sunscreen every 2 hours if they are out in the sun exposure. Next, you have to make a treatment plan according to them, okay? Because if you're doing peels So you'll have to combine this with other modalities to give better results, first of all. And the downtime has to be taken into consideration, very rightly said, because before their commitments, they want to look their best. They can't be denied treatment. Only thing, if on a scale of 10, any other patient you were giving 9 out of 10, this one might get about 6 on 10, okay? But that period where you offer treatment before the commitment is where they will have to be compliant, otherwise it falls back worse than 0.0. So you can't deny treatment, but the expectations have to be lower, and that it doesn't need to be a public figure that you're dealing with. Even routine patients, so many of them have ample amount of sun exposure. So their expectations, you have to understand the patient's expectations first and give them a realistic figure. Don't let them climb a mountain and then तो indemnity भी नहीं काम करेगा. So have a realistic picture, give them a realistic picture. Realistic expectations is what aesthetics is all about. So yeah.
So there were two reasons why we have, they'll get converted for later, but that group is this group. So you should have a good knowledge. These are subtle things. The points which have been discussed are through their experiences. They would have gone through the difficult times. They would have had the time to even to convince the patient.
Similar to this, when they come very late to us, when they have done everything wrong to themselves. This is a proper case of anti-aging, which can be managed in multiple ways and always in combination of ways. So what all things, like 1, 2, 3 things that we want to add and what sequence people want to add things in is very important. So to put the complete history, her daughter is getting married in a month's time. That's the amount of time she has given you. In a month's time, her daughter is getting married. So,
She didn't get the daughter.
the daughter
is very less. Okay, those kind of patients where they don't have fat and you cannot harvest fat, they're more muscular. You can use implants to augment the cheek or the chin. The other areas you can use fillers. So that's an option.
So points well taken on the side of fat. The advantages are many, as been told. The skin resurfacing, the longevity, the cost factor, everything. But we would like to understand now the different kinds of fillers on the other side. Dr. Seema, can you, in your experience, can you tell about how you are dealing with the patients who request fillers? Next slide.
Okay, this is a patient who came to me. Her main concern was she had a scar at the corner of her lip. Can you see that scar?
I would want a Mala augmentation. Talk
Okay.
about fillers in a bigger context.
Okay, fillers is basically hyaluronic acid. It's basically there in all our bodies, our ground substance, but they're artificially available in 1 ml syringes. You can use them. Now the fillers come in 3 ranges. That is, they are thick, medium and thin. Thicker ones are always used to get your contour or contour hard structures. Especially if you want to contour your cheek, your chin. I use it even for the nose. I also use thick fillers for the under eye where you want to augment the infraorbital margin, where there's a lot of sunkenness that is there. Medium filler, you can use it for your lip or your nasolabial fold. Thinner or fine fillers are used in the under eye region or just for rejuvenation in the cheek region. So these are the 3 kind of fillers that you can play around with. So it's not that you use only one product in a patient. You can use a thicker filler as your base, and then you can use a thinner or a medium filler on the top. You can layer it with a medium or a thinner filler, so that you give a very nice finish when you reconstruct the cheek. So for the cheek, I usually use a thicker filler to get the contour, and then I use a medium filler to get that contour or something called as the OG curve, so that when you smile, you have an S-shaped curve. The filler does not stand out like boluses, so it helps in contouring and shaping the face beautifully. So I use a layering technique whenever I have to do the cheek region or a malar augmentation. And whenever I do cheek, it's very important you also do the under eye, because when you do a cheek and an under eye, it always enhances or removes the nasolabial fold, because the minute you get a lift, the nasolabial fold looks much better because it's more lifted.
Then what about the advantage? What to to deal with that?
See,
whatever?
anything when it gets stretched, it looks nice. You just stretch or lift your skin, it looks nice. There's no wrinkle, there's no pores, there's no pits, nothing is seen. And hyaluronic acid again it has a property to absorb water. So the minute it absorbs water, it gives a nice shiny appearance to the skin because it's hydrated from inside.
So the take home is both works wonderful in good hands. So at this juncture, 2 points I would like to bring in. What is the training required to do all this a little high end, I can say, this kind of work, and they can share their experience in 2 minutes each. Fact.
Yeah.
How is the training, if anybody wants a training? Because these procedures are not ideally seen most of the times. You need to go to the places where it is done in person. Where you got to see the procedure, how you got it first and how you got...
So I've trained at a lot of places. So whenever you train in multiple places, there is always some amount of work which has a bias. Some areas might have, some of the institutions where I worked in had biases, in aesthetic surgery. They would straight away go in and do a superficial lift or a deep plane lift and not rejuvenate later. Just stick to that. Some might add some fat to it at a later stage and it is compulsory. The others might only do fat and add on some other modalities to this thing. But it's up to you what you want to actually choose. You have to pick and choose that you take the best from every place and you use your mind after that. So it's all case selective. When you want to train, you want to look at places which are giving you volume. Places which are giving you multiple options of cases that you're doing. It should not be a very thin line, just a very OPD based procedure is not going to do justice to you. If you want to learn aesthetic surgery, it is actually beautiful. Like there are a lot of things. You'll have to train. Okay, it's not going to be a one-stop solution. Every time, and every year I train. I go and train. I might be doing so much here, but every year my principle is I learn one thing new every year and without fail, probably minimum one. And to incorporate that one thing which you have learned, it takes you another year. So one thing which you have learned this year, it will take you next year to start doing it in the best possible manner. So imagine what I've learned right now, I'll start at 23, right? If I've learned at 23, I'll start at 24. So what are you doing? You're just continuing to you're just doing what you're actually doing regularly, repeatedly. It becomes monotonous over a period of time, your results become the same. You need to give the best possible results. So, yeah, training has to go on. And with the AMSI, this thing, showing us
hopefully by next year, I should start trying on to that also. There will be at least 2 centers should be coming up that will inform in course of time. Dr. Seema, 2 minutes.
Okay, for me the journey to aesthetics was my trauma patient. So after doing all the hard tissue reconstruction, I felt there was something that was missing. And I wanted to give them something more better. So that is when I went and learned about Botox, about fillers, and that has sort of transformed my practice totally. So everything started with the need. If you feel that there is a need that your patient requires, you go and learn about it, train about it, learn from. And like how Adria said, every year I also keep going for courses, learning, and it's an ongoing thing. My dad even asked me, have you stopped learning now? It's time for your kids to learn. But in our profession, everything is upgrading, everything is becoming new. There are new techniques coming. There's also a need for improving your skills. So it's very important that you keep learning, keep upgrading, because you will stop growing if you stop learning. So never stop learning, because that's where you will grow. And see, when we gain knowledge, we come here to impart it to you because we feel that there is a need and a scope for you to do better. See, it might be good in our hands, it might be much better in your hands. So it's how you're going to incorporate everything and how you're going to take it forward. So each one will have their own way of doing it. Each one will have their own protocols that you will come up with. So learn every kind of skills that you can from everywhere. Because once you have everything in your basket, and which one is good for this patient or which one is bad for this patient. So it's a learning experience.
So 2 things people, so that you eliminate your biases, because whenever you learn from one person, they have their own favorites that they have developed over time and or their experience. So you will end up doing just that and never be able to explore. So learn from a lot of places. Don't stop learning and read and reread. you cannot make all the mistakes, but you need to learn about all the mistakes. For example, especially like Dr. Neha's talked today about complications, not all of us will make all these mistakes, but we need to be actually prepared, be prepared for those complications at all times, because at that time, no, Google Scholar is going to help you and pop up what to do when your filler goes into a vessel. So read and reread, because every time you reread, because you're doing something, you will find another application of that same thing. So apart from hands-on, there's a lot of reading that facial aesthetics needs.
So the take home is a lot of arenas are there to get trained in facial aesthetic. Take one step at a time, and then you can build up your plan. Now coming to the next case, Dr. Atre, can you brief over this?
So, Rajgopal.
Thank you. Thank you very much.
Dr. Mimamsa.
We can change the background.
Yeah.
Yeah. Sorry, I think we come back.
Correct. No, that photo we will go.
That's right.
Actually, we can shut the screen if possible, the light.
Okay, thank you.
Bright.
All
Dr. Mimamsa.
I would request everybody to stay back for a group photo. All the speakers, practitioners who are.
Dr. Seema Alice Matthew. Now I would request Dr. Arun Kumar Panda to please come on stage and present the certificate to our chairperson, Dr. Shravan Kumar Singh.
Excuse me.
You should come back. Yeah, you should come back. Otherwise nobody will see you. You come back. You go down. Wrong person standing where the wrong person. That's okay. Okay, cheese.
Yes, ready. पीछे रहना थोड़ा सा वाइट करूँगा मैं पीछे आ जाओ
But it's black. So पूरा black है. Phone ना, you're talking about the picture. Phone.
Okay, done. Thank you.
दिखाने के लिए ले रहे हैं दिखाने के लिए सर बोले कि
as a single molecule, it is right. So spectrum is a big molecule. So all the big brands were
नहीं वो आप अपने
उसमें इंस्ट्रूमेंट का आपको दिक्कत भी लगे तो रिटर्न भेजने की जरूरत है सिर्फ आप ईमेल भेज दें ये इसके जरिए आपको
ऐसा होता है ये सही है भाई इसका ड्रिल बिट
छोटा बैग नहीं है
नहीं उसको रैप करो
These are the options. ये है नहीं
सर गए ना अभी उनको बोला एक मैंने
this syringe.
We have a operation of
आने वाला है ये गाना ये पेपर करना ये सेशन दिया है
There is a book which has come out between my mentor and colleague Dr. Sanjeev Nair and myself. It's a handbook.
Regressive ideas.
comes from an intact periosteal envelope. So again and again, this periosteum was given importance. Third point here is these 3 studies which are quite an landmark studies. They emphasize that the presence of infection and residual bone segments, they themselves act as an inducer of the mesenchymal cells in the surrounding tissue. So you can expect such kind of bone regeneration to happen in cases of infection, more common than if you see this patient post say benign excision of the benign lesions. So this is the last study which is very important, De Villa et al. It's not published recently, it's published in 2006, but he has listed all 5 important factors which are important for this. One is the presence of periosteum and bony fragments, the mandibular stabilization, soft tissue protection, presence of infection, and young age. Age and the presence of infection and the periosteal envelope. These are the 3 factors which are common in almost all publications till now. So the take-home message from this particular case report and going by the literature is that unexpected spontaneous bone regeneration can and does occur. Potential for such spontaneous regeneration exists in young patients and those undergoing resection following infection of jaw bones. Immediate reconstruction may be delayed in such cases. Presence of comorbidities does not rule out possibility of spontaneous regeneration. And an intact periosteal envelope has role in regeneration, but it is not the main factor governing spontaneous regeneration as seen in our case, because the periosteum envelope was definitely not intact. We have seen repeated dehiscence happening in our cases. So with that, it's just a line from the Bible that don't reject God's grace. The gods want to heal things uneventfully themselves. And this is my gratitude to all my teachers and my colleagues. Thank you. History for free fibula. On a day, and just a day before we saw this PET scan which was advised by the plastic surgeon, and that's when we got to know. So it was a 3 months time period when the entire regeneration had happened. So it was 3 months to answer your question.
Was there a segmental resection done in the anterior mandible?
Yes, it's a segment.
And she doesn't want to undergo any of the treatments. So everybody may not be privileged, that is gums, teeth and the lips. So I would like to describe the 3 smile lines, which would be a low smile line where 75% of the teeth would be visible and no gums are visible. And the second would be a moderate smile line where the interdental papilla along with 100% of cervical aspect of the teeth is visible. And a high smile line where along with the teeth there is a 3 to 4 millimeter of the gingiva that is exposed, which we would call it as a gummy smile. So is it really necessary to treat a gummy smile as such, just looking at it? So gummy smiles are not necessarily displeasing if certain rules are respected. That is, the incisor curvature should follow the contour of the lower lip, as well as the contour of the upper gingiva should follow the contour of the upper lip. So it is thus up to the patient to decide whether his or her gummy smile is displeasing. So now comes the question, not every gummy smile needs to be managed surgically. So it is also to respect the patient's decision, based on which we have to go ahead with the treatment plan. So it is very easy to come to a decision that this is a gummy smile, but it is really difficult to come to a consensus or the alveolar component is good, but it would be because of only the soft tissue, that is the upper lip line, which would be less than 20 millimeters, and hypertonicity of the upper lip where the patient smiles, so which leads to over contraction of the upper lip, leading to visibility of the gums. So I would just like to take you through a few cases which we have managed in our clinical setup. So this patient is highly demanding, where he was demanding like, I never want a surgery to be done, but he wants his gummy smile to be corrected. So he was very adamant, saying that it has to be corrected but not touching my jaw. Giving him all the different treatment modalities. So where we managed giving him a Botox injections for him.
Little dull. So this is just an example. Post-operatively again, soft tissue color was evaluated. You can see from 51% on, by the second day, by preserving the oral mucosa, the color of the soft tissue had improved to 63%. The cases had a normal color. By the 7th day, it was almost 92%, and by the 14th day, at the end of 2 weeks, the soft tissue had retained its color. So this is a case where the soft tissue has been preserved. The involved mucosa was not removed. The soft tissue was preserved and the primary closure has been done. The 7th post-op day, the mucosa color was normal. At the end of 3 months, we also evaluated for the presence of soft tissue defect. Post-operatively, in some cases we had dehiscence. It was around 8 cases, and we had a minor defect, nothing crossing 4 centimeters. The average size, it was only in 8 cases, and the mean size was around 2.5 centimeters. The post-op day of oral feed was also noted. More than 60% of the cases, around 58% of the cases, around 29 of the 51 cases, we started oral feed within the first 3 days. It is mainly within the second day, post-operatively, the second day we start. In these cases, we do not give an NG feed, NG tube. By the 7th day, around 78% of the feeds were done, and for all, except for one case, who had almost complete loss of tissue where we were not able to, initial stage of mucormycosis, we started feeds for all the patients. So on this, the rehabilitation part, within 3 months, we were able to rehabilitate 31 cases. And within the 6 months, most of the cases except 10 cases were rehabilitated. At the end of 6 months, final denture, we were, many patients had opted to go for final denture in their hometowns. So we did a univariate analysis to compare the predictor and the outcome variable. Our outcome variable was whether a soft tissue or an oral defect was happening or not. So we could see that none of the, we consider the clinical findings as a predictor variables. So we could see that the p-value is insignificant. The presence of the oral defect was insignificant of the predictor variables. See the abscess in the third picture in the preoperative and the change in the color. Intraoperatively, the parietal and labial flaps have been raised and just the bone has been removed and little bit of curettage of the soft tissue was done. This is post-op 3 months. We can see, this is in the first picture, we can see a small, it's not very clear there. There's a small hole, less than a centimeter on the left side, which could be covered with just an interim plate. We do not require an obturator, we do not require, and the patient was able to feed very early. So I would like to conclude by saying that though mucormycosis is lethal and rapidly progressing, our aggressive nature should be curtailed to the bony structure. If we can preserve the soft tissue, we can reduce the functional and aesthetic mobility in such patients, and we could also and the strong platform to present this case. Thank you.
Conclusions would be significant considering the number of cases. I have one question for you. Like you have stratified your cases into based on the clinical appearance of the mucosa, correct? So where post-operatively did you use the same stratification to see the post-op outcome?
Yes, sir. Whether what the color, what the appearance, what it would be in this type. So the same outcome was the preoperative and normal, pale, dull or dark or necrose. The same was followed.
So it was not there because of the proper osteotomized and positioning of the bone. Coming to the second case, where the patient presented to us with the complaints of the proptosis and the progressive decrease in the visions. So clinically, you can able to appreciate the proptosis also. So we did think about what are all the steps will be included in the axis osteotomy. So the first step should be the elevation of the flap. Since it is an anterior cranial base, so we always better to go with a bicoronal flap. So as everyone knows that it starts from superficial temporal line. So the flap should be elevated in the subgalealic plane up to the level of the nasons. So the second step, once the flap is elevated, the second step should be the markings. So the first is 2 skeletal osteotomy, 2 steps osteotomy can be done. First is a frontal and followed by the orbital. The frontal osteotomy, so the first step you have to place a burr hole. So burr hole can be placed in the glabellar regions and in the key areas. Temple's key area, it's called as a region where it is present behind the eye, in between the forehead and the ear. So you have to connect the burr hole regions, and then this articulation of frontal bone should be done above the supraorbital rim. So one can able to appreciate that the disarticulation has been done above the supraorbital ridge. The second step, once the frontal bone has been disarticulated, the orbit bone has to be disarticulated in order to gain a vision. So accessibility to that region. So we did that. The osteotomy should be done along with the supraorbital rim, orbital roof and the glabella as an end block. So this has been done, followed by, after doing this, the exposure of the tumor is much more easier. So you can able to directly enter into the tumor. So this is a picture shows that the tumor has been exposed, followed by the excision of the tumor, and then the final step is the most important step. Whatever the osteotomies we can do, but this final step is that we have to reposition it in a proper manner in order to regain the aesthetics of the patient. So it has to be repositioned using a mini plates. This shows that reposition has been done using the mini plates. So the third case is, as I told, that it is also used for the vascular pathology. So it's one of the cases that shows that the patient is having an anterior communicating artery aneurysms, where we have done a frontoorbital osteotomy to reach the site. So there are various treatment plans for the aneurysm. Either we can go with the clipping or we can go with the flow diverter, or coiling can be done. So in this case we did a clipping, surgical clipping. So this is a picture which shows that the osteotomy has been done, and this slide shows that the surgical clipping has been done for the ACOM aneurysm. So it's anterior communicating artery aneurysm, surgical clipping has been done. So the last case is the olfactory group meningioma. So this is a case where the patient presented to us with the complaints of a severe headache and decrease in the vision. So the patients, this is a very such wide tumor, so it's very difficult to reach the tumor directly. So in order to pave the way, so we create, so advantages of fronto-orbital osteotomy. It's most commonly, they will have a minimum cerebral trauma, frontal lobe retraction will be minimized, and one will have good extra and intracranial overview, and the wide exposure, as I showed you in the CTs also, you can able to have a wide exposure of orbit and orbital apex, improves the maneuverability of the surgeons. If something has an advantages, they will also have the limitations. So the limitations, there may be a transient damage to the frontal branch of facial nerve can occur, and there may be a certain transient periorbital swelling and anaphthalamus can be occurs. Sometimes there may be a CSF leakage which can all be avoided. So coming into the conclusions, so take your message is that fronto-orbital osteotomy, not only for craniosynostosis, it is also used to approach the
context perfectly. Hall, well, you know, we all have seen Julia Roberts. She has a beautiful smile. The smile, whenever she smiles, it just jumps up to show her gum. Would you want to treat her? That is a hyperactive upper lip. Then a short upper lip or a combination. The patient right on the dental chair, where you make them sit upright with the jaw, the lower jaw parallel to the floor. And we already know what are the weapons we have. We have the Laforts, we have BSSO, VSSO, and these are the only limited things. So where and which area to choose what. So first is seeing a patient in their vertical thirds. So when the lower third is long, because we majorly understand and work with the lower third, which is either long or short. When it is long, it can either be a VME or a mandibular or a chin excess. Then there is upper lip. 20 or more, perfectly fine. And if, even after that, the dental, there is a show of teeth. That is not because of the short upper lip. Please do not classify it as short upper lip. It does not come that way. And the teeth at rest. These people will have a teeth at rest and a gummy smile only in case of VME or a long face maxillary excess. These are the patients that we treated. The first one, as we can see, that's a vertical maxillary excess. There is lip incompetence. The second one, repose, very minimal. That can be very specifically handled with an anterior maxillary osteotomy or Bosman Cole. Same, another one, the feature. This patient is yet to go for surgery, but this is how the profile would change. So this is something that you can do at your clinic under 8 minutes review. So these are the coming to the deep bite cases. They are very difficult to treat. However, orthodontically must be managed more, and then you can come for a BSSO advancement. The rest the orthodontics can handle. Coming to the evaluation of the maxilla, first giveaway of a hypoplastic maxilla will be a paranasal hollowing.
So,
Dantrolene sulfate, sir?
Dantrolene sulfate is what she told. I think we should give it to them. Yeah. So,
Dantrolene sodium.
Close to it. The answer is dantrolene sodium.
Yes, yes.
Dantrolene sodium. Dantrolene is good. Direct question to team B. A patient of fracture of zygomaticomaxillary cardia and occasional ectopics. Can you enumerate on the reason for? You have 20 seconds to answer this.
Oculocordial reflex.
Perfect. Yeah. Trigeminal-cardiac or oculocardiac reflex is the time's up. Team C, would you like to take the second part of this question? No. Would you like to take the second part of this question? IV atropine. Perfect. Atropine, intravenous is the drug. So team B gets +5. The second part. We move on to the next question for team C. Name the test which is used for assessing the airway with patient's mouth wide open, with visualization of the fascial pillars and soft palate, with the tongue in maximum protrusion. You have 20 seconds for this. Time's up. It goes on to Team D. Would you like to take it, Team D? Perfect, perfect. Very nice. Team D gets a +5 on this. The second part of endotracheal intubation in a patient with severe restriction of mouth opening. Very nice. So you get a +10 on this. So your answer, that is what your answer was, for the audience to know. So we move on to the next question to Team D. A patient presents with a sensation, pricking sensation and pain along the lower lip on tapping in that area and has had a history of fracture a month back. Can you tell what sign is being elicited here?
That's the answer.
Very nice. You get that right? I don't think so. That is the answer for. Comes on to Team A. If you want to make an, you have a negative mark for that. Methacobalamin will give it to you. That's the right answer. Team D got it right in the first place, but they had a mistake.
And we can use an occlusion splint also to fix a mandible in one position. Why we should remove a broken instrument? Number one, it's a foreign body. So patient will, if the patient know, he will also have in his mind that something is there in my body. Then they can undergo infection. Then fibrous granuloma can be there, nerve injury can be there. To conclude my presentation, I would say that first of all we should avoid the complication. Then for avoiding the complication, the pre-operative inspection of instrument is must. And if it is there, try to remove it. If you fail, then also you endorse it and post-operatively follow it. And if you cannot remove it, it's better to refer the patient to some expert. These are my references. Thank you.
Nice presentation. The first case was done under GA, right?
Yes.
Was it that so significant that should be taken under GA? Did the patient have any complaint with them?
No, sir. Actually, we did it under GA only because of, first of all, the patient was a case of failed extraction on the same day. So when he came to us, already he was in he was problematic and in painful situation. So we just only thought to remove it in a planned way, so that we do not give a once again a failed attempt. So what we did, we removed the root stump on that day only, and then we went for CT scan, and the earliest OT which we could get for the patient, we removed on that day. The idea behind operating under GA was to avoid any discomfort and pain to further to the patient, and to prevent the another failed attempt. That was the only idea.
Thank you. We have Dr. Karan Sablok, who will be presenting on efficacy of posaconazole over amphotericin B, management of serious systemic fungal infections.
You have to actually put in a deliberate bend.
You don't
leverage of the plate. Okay?
If you put a straight plate, you will act without, inadvertently you will end up.
You cannot make the segments align, otherwise you will get a condyle. The moment you lose the arch, loosen the IMF, it's going to spring up.
The moment you see the proximal segment knocked out, kicking out like that, put a deliberate dent on the plate. Yeah, please ask me.
2 minutes after this, you can continue the discussion. One.
Thank you very much for patient hearing, although it is very difficult after lunch.
That's why I didn't have it.
Dear persons, to kindly announce the best paper for this session. Vijay Lakshmi. Dr. Preeti Sharma. Dr. Thomas. Dr. Lalit. Thank you very much.
And good job by everyone. Interesting cases and interesting discussion. So to come up with one paper of the session, it goes to Dr. Ravindra Singh Semi for surgery first orthopedic approach.
Thank you, doctor. You can collect your certificate from Leela Khan at 4:30. Contact Dr. Prabhu. Dr. Gurgi is in charge scientific community. Leela Khan.
Surgery first orthopedic approach. First session 1 also.
Thank you.
Which was extending on the left side, and also there was obvious lingual and buccal cortical plate breach that could be seen on the sections. Now, according to the CBCT, they had given a diagnosis of a benign odontogenic tumor with respect to the left mandible with a differential diagnosis of ameloblastoma or OKC. So we went ahead and did an incisional biopsy of this patient, and we came to know that there was the presence of few plasma cells which could show a possibility of multiple myeloma or a plasmacytoma. We also went ahead to go for an immunofixation test where we saw that there was a significant raise in the kappa light chain, which was again suggestive of the multiple myeloma. The patient went ahead and got a PET scan from the vertex to thigh PET scan, where the report said that there was no metabolically active significant lymphadenopathy seen anywhere else in the body. So here I would just like to draw your attention to something that we can say is a primary manifestation, where we are using this as a modality to diagnose a systemic condition like multiple myeloma. It is 1% of all malignancies and 15% of all the hematologic malignancies. So each oral lesion has characteristics and clinical features which help any clinician to diagnose them. However, some conditions have similarities in their manifestations. They have a lack of accurate definition. There is an incompatibility between signs and symptoms, and all patients do not come with the same manifestation. So this leads to error in your clinical diagnosis. Two studies that I would like to highlight. One that shows the clinical and histopathological diagnosis, that is the compatibility, where we see that fibro-osseous lesions show 91.2% incompatibility and hematologic disorders 100%. And also when we go to check for the agreement rate between radiographic interpretation and histopathologic diagnosis, back in 2013 it was up to 80.4, and today the concordance is only 49%. So this presentation, I just wanted to highlight a few easy, common but uncommon points. that something we need to remember is the iceberg phenomenon. Any condition can look small but turn out to be something very serious or something very unusual or something very unexpected. So the three most important points that we need to remember is the clinical, radiographic and histopathologic evaluation before we come to any diagnosis and plan any treatment for any kind of patient. Also, one more small point that I would like to highlight in today's time is that the importance of further investigation, that is post immunohistopathology. It is important for many other conditions that we go in for a histochemistry test, because sometimes we do our pathological report says we need to correlate, it may or may not be, or it could be a descriptive analysis where even they do not give us a final diagnosis. So instead of just picking up the scalpel and starting to cut, probably we should come closer to the diagnosis before we start treatment. So therefore, the topic for today, to be forewarned is forearmed. So to be prepared is definitely half the victory. I'd like to thank my mentors, my guide, and my team and my colleagues with who I have seen these cases. Thank you.
In the second case, you said that CT scan was already done for the patient when he had come to you.
The CBCT was.
CBCT.
Yes.
So, what is the point of repeating?
Dr. Ajit Chandrasekhar. Dr. Pallavi Karadigudi. Dr. Himanshu Thukral. Dr. Major Ashok Kumar. Dr. Janvi Modi.
Sir, please.
There will be a best paper for which you will get the certificate after 4:30 in first floor, Lilac Hall. And
It's a way going to the internal jugular. From the structure in the midline, some structure in the midline going to the internal jugular. I mean, can we give it to them? It's middle thyroid, they said inferior thyroid vein.
Because in anatomy you cannot substitute one for the other.
You get a minus 5 for this, unfortunately.
Inferior thyroid is inferior thyroid.
In C, can you identify the structure? Time's up. In D, you want to take it? It's the wrong answer. Minus marks. It goes on to team A. You want to take it? Passes on to team B. You wish to answer this? You don't wish to answer this. Can we go to the audience now? We have a hand there.
Show the photo again.
Can we have the hands, please? That's the right answer. Can you come here, doctor, please? It's marked right after its division into the superior thyroid and the maxillary arteries. So it's the external.
I'm doing a third year PG in AIIMS, New Delhi.
Congratulations. The observers feel we can substitute this. I think we should. This is for you, team D. You need to identify. You want to take this one?
The question will get evaluated.
You want to take this one? Perfect. A perfect answer. That's the Stenson's duct of the carotid gland. You get a plus 10 for this.
You people are answering well. Kindly make it loud so that we know that it's a.
Can we have this last question for the audience? This is only for the audience. Somebody from the audience wants to take this structure. What a perfect answer that was. Please come. Please tell your name, doctor, and the institution you come from.
My name is Dr. Ashwini. I am from SDM College, Dharwad, Karnataka.
Team A. We are on to the armamentarium round now. Very nice. Right answer, it's a transbuccal trocar.
Sir, trocar and cannula, sir. It's trocar.
The trocar and cannula is used in multiple areas. You have to say specific.
Sir, transbuccal, trocar and cannula.
I think we should.
Give them another question. Awarded. Awarded.
You award this question?
No, award the marks.
Award the marks. Okay. So, we award the marks. That is the right answer.
But
can we have the right?
For all teams. If you see the complete component, you have to answer.
See, can you see a sleeve there? Sleeve is also.
The correct answer would have been a transbuccal, trocar, cannula and sleeve. That would have been the complete description of this armamentarium.
Here, that is not the rose zygoma elevator. The question moves on to team A. C, you want to take this? Do you wish to take this?
Yes, sir. So, rose disinfection forceps.
Right. So it's a pair of rose disinfection forceps. You get a plus 10 for this. Team B, you lose minus points in this question. We move on. Next question. Team C, be ready. Image for you. What you see?
Sir, Ashley's nasal forceps.
You Hayton-Williams forceps. Again, I would like to give it to them.
Yes.
You would like to have both.
Both is
Can you tell both more descriptive, answer? There are two instruments. Still, we would give it to you. So we award plus 10 to them.
You cannot award complete marks. Award 50%.
So the name of both still remains the same. It's
For the sake of completion, they have to answer. We made it clear in the beginning. No, if we have a athletic award, it's
give an introduction. Please tell your name.
I'm Dr. Hetri Saxena from Mahatma Gandhi Dental College and Hospital, Jaipur.
Hamper in this question. Those you say on one hamper on this question. There are no hands we see. Come on, take it. You have no points to lose. No, it's not used in the maxillofacial area. So this instrument is used for. That's you are. Can you speak it out loud for everyone? Rib osteot. It's not an osteotome.
Advanced retractors.
You have the word right, but that's not a retractor. I think we can still give it to you. It's a rib shear. Yeah, come. Tell your name first if you want a photograph.
Myself, Dr. Saurabh Oza. I am from Index Institute of Dental Sciences.
Last, there. Right. So I would like to thank Orthomax. They have been very generous. They provided the catalog, and Orthomax has also sponsored prizes for all the candidates here who have participated in the quiz. Big round of applause for them. Doctor, your name?
Dr. Surinder.
Dr. Surinder from?
PGI Chandigarh.
PGI Chandigarh. Congratulations. Considered as in. Yeah? Your willingness to answer. Huh? Only one participant answers, both do not answer. In case we get two answers from one team, that disqualifies, or you might get a negative as well. Yeah? So you can discuss and answer. You have 10 seconds to answer the question. Yeah?
And once they raise the hand, they cannot pass. They have to answer.
This, yeah. You all cannot pass the question once you have chosen to answer a question. You will have to answer that question. Yeah? And this round has a negative marking of -10. You know, +10 for a right answer and equal negative, that is -10 for a wrong answer.
They wanted to know the score before this one.
Dr. Chamandi, are we ready with the scores for till the end of round 3? Where are we?
Team A, total 33 marks. Team B,
Team A is on
33 marks.
33. Team B
55.
is on 55. C
Team C is on 45.
45.
Team D, 90 marks.
Team D still leads with 90 marks. Sirs, we are ready? Yeah. We start. Perfect, yeah, you got it right. The first, you need to name 3 structures which passes through the tendinous or annulus of Zinn.
Optic nerve, ophthalmic artery,
Complete it, still you can answer.
Will I get negative marking if I say this?
Still, if you want to tell one more structure.
Marks are given already.
Open answers.
Now you won't lose.
Now you won't lose them. You can answer. No negative marking.
Abducer.
They said abducer.
Anyway, they get the marks. We have already declared it.
Transferred in mass, sectioning the feeding vessels of its axial arteriovenous system is known as. Time's up. None of them has attempted this. Question goes on to the audience. Anyone from the audience here?
I'm Dr. Shilpa, third year PG from KLE, Bangalore.
KLE, Bangalore. Very nice. Artery. Time up for all.
It's an axial pattern flap.
Pattern flap. Come. Sorry, I can't take you. That's the right answer. Can you read it out loud? Can you fill in the blanks?
Axial pattern flap.
Based on the
branches of internal mammary artery.
Very nice. That's the right answer. Can we have your name, please, sir?
Dr. Mahendra M. Katia from Index Dental College, Indore.
Indore. Very nice. Congratulations. Photo. We have prizes which are sponsored by Orthomax India. There are cash vouchers for the teams from Orthomax India, which the teams can redeem before 30th of November. There are cash vouchers worth 15,000 rupees for the first team, cash voucher worth 10,000 rupees for the second team. The remaining 2 teams also get vouchers of 5,000 each. Yeah? So we have the results. So we have team A on 44 points total at the end of round 4. Team B on 75 marks total. Team C on 45 marks total. And Team D leads by 110 points. So we have first Team D, and first runners up is Team B with 75 points. Bedi with us, who's the CEO of Orthomax India. I request him to please come up on the podium. We need to hand over the prizes to our participants. I as well request humbly our observers, Dr. Ritesh, Dr. Dinesh Verma, Dr. Vasant, to please come up on the podium to hand over the prizes to our participants. Who have taken up the online quiz event, they have their certificates of participation ready. Kindly, after the ceremony, kindly meet us so that we can hand over those certificates to you all. So I want Dr. Balakiran and Dr. Rajesh Khanna from Sri Ramchandra University Chennai, who are the first in this competition. Dr. Rekha Yadav and Dr. Rameshan from Armed Forces Medical College, Pune from the West Zone. They are our first runners up. Dr. Frijo and Dr. Gupta Vyakhya. The North Zone, Dr. Shruti Gupta and Dr. Swati Bharadwaj from Sardar Patel Institute of Medical Sciences, Dental Sciences, Lucknow.
Dr. Gunjan was doing so much effort. Thanks a lot, Gunjan, for that.
Dr. Asta Piyush Bhai, Dr. Samyak Dudhe, Dr. Anish Patole,
Not expecting that. We didn't answer any question. We answered any question.
Dr. Rutvi Pandey,
Thank you.
Dr. Shravan Jagdish,
This is what
Dr. Anubhav Abhinav Sundar, Dr. Soham Lahari,
Thank you.
Dr.
Other 2 3 years lifetime achievement.